Welcome, and thank you for joining tonight's Ask the Experts virtual event, Navigating Every Stage of Menopause. I'm Dr. Pelham Batour, fellowship-trained women's health and menopause specialist at Cleveland Clinic. Joining me are fellow obstetrics and gynecology specialists from Cleveland Clinic. The Cleveland Clinic Obstetrics and Gynecology Institute is dedicated to delivering world-class care for women of all ages. Our team provides compassionate, coordinated support for a wide range of women's health concerns, including general gynecologic care, childbirth, infertility, incontinence, gynecologic cancers, pelvic floor disorders, menopause, and much more. With locations across Northeast Ohio and beyond, we would be honored to care for you if you need us. We are here to answer your questions, share our expertise, and provide clinical insights on what to expect during perimenopause, menopause, postmenopause, finding relief from symptoms and when to seek treatment or preventive care, and how menopause and midlife affect your mental and physical health. We had more than 440 questions submitted for tonight's event, so we will do our best to answer as many as we can. We will also send out an email after that event, after the event, so that you have menopause and women's health related resources. Before we get to our questions, I'd like to let the panelists take a few moments to introduce themselves. They'll each share a bit about their backgrounds and address some common misconceptions they hear about menopause in their daily practice. To kick things off, again, I'm Dr. Pelham Batour. I'm a professor of OBGYN and reproductive biology, and I am the medical director for our Women's Comprehensive Health and Research Center. And just a little bit about me, I've been here at the Cleveland Clinic since 1998, so just a few weeks shy of 27 years here. I work mostly at main campus, right now only at main campus, and my areas of expertise, I actually work as a consultant for my colleagues, so not necessarily the first line menopause care, but if there are complexities to the care, hormone therapy is more risky, those are the situations where I'm asked to consult. And I was asked too about what one misconception about menopause you often encounter, and I feel like there are just so darn many. But I think the big one is the absolute all or none approach. So yes, this is the fountain of youth and we all should be on it. Well, there's nothing like that in medicine, correct? It's always about individualizing decisions, and also sometimes us being too restrictive. We're just so worried about the risks that I think it's important that if women are told and counseled properly about the risks and benefits, sometimes even if the hormone therapy is more risky for them, they should feel empowered to make that decision for themselves instead of us making it for them. So that's not necessarily a misconception, but sometimes it's a misconception that you can absolutely not have hormones in your situation. Next on the panel, I'd like to introduce Dr. Catherine Caponero.
Hi, my name's Dr. Catherine Caponero. I am a staff physician at the Cleveland Clinic. I work at Beechwood Family Health Center, and I operate and do deliveries at Hillcrest Hospital. I am a true generalist. I take care of adolescents all the way through women in their hundreds. I feel so lucky to do my job, and I feel very privileged to help people in this way. I'm also the Specialty Quality and Safety Officer for our institute. In regards to a common misconception, one of the most common misconceptions, I think, is that just because something is quote unquote normal doesn't mean you have to deal with it. I think it's really important to know that we have a lot of tools in our tool belt to help make women's lives and patients' lives better. And it's so important that you talk to your healthcare provider about how to impact your life in a positive way if something's bothering you. And I want all of my patients and all of our patients to feel empowered to do that.
Thanks, Dr. Caponero. Next, I'd like to introduce Dr. Jacqueline Collins.
Hello, my name is Jacqueline Collins. I'm also one of the staff physicians at the Cleveland Clinic. I see patients at the Columbia Road office in Westlake, Ohio, and I operate and deliver out of Fairview Hospital on the west side. I have a special interest in hormones, both from a perspective of caring for my patients going through menopause, as well as my patients who identify in part of the LGBTQ community. And so I manage hormones from multiple different perspectives. I'm also interested in sexual health and the relationship side of patients' mental health. So we spend a lot of time talking to patients about that as well. One of the most common misconceptions that I encounter is patients who've seen other physicians or other doctors and been told that if their main complaint isn't hot flashes, that hormone replacement therapy isn't necessarily for them or helpful, and that some of the other symptoms that they might find more bothersome can be dealt with in other ways without going to hormone replacement therapy. And while I think there are many approaches to dealing with all these symptoms, I don't necessarily agree with that. And I think a lot of patients come to me after having suffered through that for a little while.
Thank you so much, Dr. Collins. And our last guest is Dr. Jacqueline Zaponsic. Dr. Zaponsic?
Hi, I'm Dr. Jacqueline Zaponsic. I am a generalist OBGYN at Akron General. Much like Dr. Caponero, I operate and deliver babies as well at Akron General Hospital. I have a special interest in menopause and also in women's sexual health. I practice at Akron General Hospital, and I've been practicing there about 7 years. I'm also the medical director for Akron General OBGYN Outpatient Services and the vice chair at Akron General OBGYN as well. I have locations at Akron. I also have locations in Greene and Fairlawn, Ohio. One of the common misconceptions that I receive from patients in the office is that they want hormonal testing to tell me how close they are to menopause. And so often there's a lot of education surrounding the fact that there are no labs that can actually predict when menopause is coming. It's purely, or most commonly, I should say, a clinical diagnosis. And that diagnosis is given after we've stopped having periods for 12 months. And so hormonal testing can help us in some ways, but doesn't really tell us when that transition is going to happen for any individual woman.
Such an important point, Dr. Zaponsic. So now that we've gotten to know our panel, it's time to answer your questions. Again, we received more than 440 regarding how to manage menopause symptoms, hormone therapy, and more. So we'll attempt to answer as many as we can for the next 45 minutes. So our first question is, and looks like this one might be coming to me. What are the first steps to dealing with menopause, and how should I bring it up to my doctor? Most individuals, not all, but most individuals prefer to do some sort of investigating online their own research before coming in, which is just fine. But I do recommend reading from reputable resources that are going to give you credible and accurate and safe information. So in general, reading from a .edu or .org would be preferable than a .com. Because in the .edu and .org, you're usually going to have more trained professionals that are putting that information together. And the second part of the question, how should I bring this up to my doctor? This is probably one of the most important questions, and I will keep saying this until I retire. I think one of the biggest reasons that people feel not heard or they feel like they're being, dismissed is because people bring up these really important questions at their annual visit with their GYN and with their primary care doctor. And as you should, because it's important. But know that healthcare provider is probably going to ask you to make a dedicated visit if you really want to dig deep, because these conversations do get complicated. It's not easy. So please make sure you're carving out enough time in that healthcare provider's clinic so that you get the care that you deserve and the conversation that you deserve. And I will tell you as an aside, like 20 years ago, it was so simple doing preventative visits. It was everybody got a mammogram, you did a pap test, at least every few years, if not yearly. And now, before the doctor even walks into the room, they're doing all this assessment of your risks of various cancers and various conditions, and it's very individualized. So even preventive care has gotten so darn complicated, which is why sometimes I feel like people feel brushed off, and probably not the intention of the doctor to do that. Let's go to our next question. This is for Dr. Collins. How can you be sure the cause of your symptoms is menopause and not from another underlying condition?
I would second the idea that so much of the way we care for patients now is individualized, as it should be. And I think that that's a wonderful approach, but you do need to sort of have that time and take that time to individualize the care to the patient. And I think that also has to do with the individual symptoms that that patient's experiencing. So when you sit down and you have that conversation about the particular symptoms, I think that it takes some time to delve into those symptoms and maybe to do some additional testing based on the symptoms themselves to rule out additional sources, to rule out other reasons why a patient might be experiencing those symptoms. Once you've done that and are comfortable that the symptoms that the patient's experiencing are not from another source, then I think moving forward with, talking about various treatment options, sometimes even just as a trial and error can be helpful, and seeing if you can treat the patient's symptoms that way.
So helpful because, fatigue and other non-specific symptoms, you're absolutely right. We don't want to just assume they're menopause and actually investigate it a little further. This next question is for Dr. Zipancic. What is the best option to alleviate fatigue and feel like myself again? Will I ever have the same energy level as before menopause?
Launching after Dr. Collins, ruling out other things, we have to remember that fatigue, like many other symptoms in menopause, is multifactorial. And it's a very common symptom that a lot of us do have even outside of menopause. So its approach for treatment is also kind of a multifactorial approach. So when we think about things that may not necessarily be related to menopause, we think of things like low B12 or anemia, even vitamin D deficiency or thyroid dysfunction. So often the best place is to start with looking at those more maybe non-menopausal diagnoses and evaluation for those and treating those underlying diagnoses if we find them first. But it's really, if those things are negative, then, there are several reasons that menopause can lead to fatigue. One can be an association with increased anxiety and depression in menopause. We know that menopausal transition can be linked with mood changes, and mood changes are often associated with fatigue as well. So if you feel like that's maybe something that you're experiencing, you're not alone. But it's important that if you're feeling that way, to be evaluated by your primary care doctor, a GYN, psychology, or psychiatry to talk about therapy or medications. We've found that estrogen doesn't necessarily treat anxiety or depression, but it can enhance mood. So it can be used for that as well. We'll also find that in menopause, when our estrogen levels drop, we have a lot more sleeplessness and more nighttime awakenings, and that is definitely associated with fatigue the next day. So there are some non-hormonal things that we can do before jumping right into hormone replacement therapy. So things like sleep hygiene, turning down the lights in the evening, don't engage in like screen-based activities an hour or two before bed. You could consider over-the-counter sleep aids like melatonin or Unisom to help you get to sleep. Typically, I would recommend avoiding like habit-forming sleep medications whenever you can. And then, of course, if those aren't working as first-line therapies, we could always touch base about hormone replacement therapy, and if you are a candidate for that, because inevitably replacing that estrogen that has been, lost or decreased in menopause is going to help improve that sleeplessness. Progesterone can do it as well.
This is a good question that I'm happy to take. Is there a role for the use of menopausal estrogen for mood swings during perimenopause? This can get a little complicated. So the short answer is yes. We actually have studies that show, not as many studies as I wish we had, but we do have some studies that show that postmenopausal doses of hormones can help mood, because for the perimenopausal time period, that turns out to be a window of vulnerability in terms of our mood. And in fact, a lot of people, there's light at the end of the tunnel. Once the hormone levels drop and they stay stable, they feel a lot better. And what makes perimenopause really tough is that it's the wild swings that people don't like. So there's something called loop cycles, luteal out of phase events, which means that, you're not done with your one ovulation yet, and boom, another one starts coming in, and your estrogen levels can go sky high, and then going from high to really low, and other times where you may not produce enough estrogen or progesterone, and they're hanging out in the low levels. So sometimes when it's the really high levels, it can cause breast tenderness, feeling moody. A lot of times that's why migraine headaches get worse, because they go really high and then drop down. And then, 3 months later, those symptoms are better, but now you're experiencing more vaginal dryness and hot flashes. So it's that irritability. We do know low-dose birth control pills probably control that up and down swing the best, but it doesn't have to be the only thing that we offer, because the pros and cons, the birth control pills, to be honest, is hormone replacement, right? It's giving you a steady estrogen and a synthetic progestogen at the same time to keep levels nice and stable. So some individuals prefer to do postmenopausal hormone options. There's some pros and cons to that. The pros is that it's a lower dose, and so because it's a lower dose, it has a lesser chance of blood clotting. So that's a good plus. The downside is that it's going to usually help you when your symptoms are low in the cycle, but if you're already having symptoms because the estrogen level's high, and those loop cycles can happen anywhere from a third to a quarter of the cycles, it's not going to control that. So when I'm using postmenopausal hormones during the perimenopausal time frame, I tell people, as long as you're okay with, people want a more natural approach or they want a lower dose, which is fine, but it's probably going to control some of your symptoms, including the mood, help some of the time, but other times you're still going to probably feel hormonal, and are you okay with that? The one other downside of using postmenopausal hormones during the menopause transition, no matter what symptom we're talking about, whether it's mood or for the brain fog or for energy, these are the things that I call the atypical symptoms. Not atypical in the sense that people experience them, but it's atypical in the sense that we don't have convincing data that giving you hormones is going to fix it, right? So in these situations, it's good to be flexible with patients. If it's appropriate, let them try these things to see if they feel better. But the postmenopausal hormone doses, since they're a little bit lower, it doesn't do a good job controlling bleeding like the low-dose birth control pills can. And this is a time of life where we already are predisposed to abnormal bleeding patterns to begin with. And bleeding, evaluating bleeding is necessary to make sure there's no sinister cause for it. But it can be uncomfortable, you know. And so those are some of the pros and cons as you're weighing what you want to do for mood. Obviously, the antidepressants and things are still available, and I think everybody in America can use a psychologist. We live very stressful lives. So in addition to doing more of the holistic things, hormonal treatment options are available and can be helpful both in the premenopausal hormones or postmenopausal hormones. But if you're using the postmenopausal hormones during that time, there are some caveats to consider. Dr. Caponero, this one's for you. How do periods change as you approach menopause?
So as patients approach menopause, it's really normal to find those menstrual cycle irregularities. This can typically happen when cycles are equal to or more than about 7 days off compared to previous cycles. So if you were having regular cycles and now you're persistently having cycles that are more than 7 days longer or shorter than a previous cycle, it may be the beginning of perimenopause. So perimenopause begins with the onset of menstrual cycle irregularities and extends beyond the final menstrual period to include 12 months after menopause. This is really important because this includes those highly symptomatic years. And this perimenopausal period can typically last from 4 to 10 years.
Dr. Collins, wrapping back around to you, what are the best vitamins and or supplements to take for menopause symptoms?
Some of this has to do with the individual's symptoms, but generally speaking, a balanced diet is one of the best ways to get a lot of your vitamins and supplements, to do it that way, to do it through food. I think one of the things a lot of patients come in complaining about during perimenopause and menopause is some of the inflammatory effects and inflammatory changes. So I do often have conversations with my patients about good vitamins and supplements that can manage or help with that. We talk about vitamin D. I've practiced in many cities, and for some reason, my patients in Cleveland have some of the lowest vitamin D levels of anywhere I have ever seen. And so replacing that vitamin D, I think, is very helpful, in addition to just a good, regular, women's one-a-day multivitamin. I also talk a lot to my patients about things like turmeric, cilantro, cinnamon, your great natural anti-inflammatories. Sometimes we do talk about trying sort of a low inflammatory diet, maybe a gluten-free or dairy-free for a while to see how that makes them feel, and then individualize that to the patient themselves.
Very helpful, because this comes up a lot, and I know the Menopause Society spends a lot of time, money, effort, expertise to review all the supplements that are touted for hot flashes, and unfortunately most of them haven't been shown to be helpful. But just like you said, there's a lot of other symptoms of menopause where supplements can sometimes have a role. So thank you for clarifying that. Dr. Caponero, how long will I have hot flashes and what causes them? Can they stop and restart during later stages of menopause?
Hot flashes typically last around 4 to 7 years. but some women do experience them for even longer, even into their 60s and 70s. This is primarily caused by those hormonal changes, specifically a decrease in estrogen, which can affect the body's temperature regulation. While it's not common for hot flashes to disappear completely and then return once menopause is established, they sometimes can be episodic, meaning that they sporadically return after a period of remission.
So next, I have this three-part question. It looks like this one I can take. Please speak to hormone replacement therapy. How do you know if you need it? What are the pros and cons? I think there's a movement to move away from the term hormone replacement therapy because it's confusing since we're not really replacing. It's the new preferred term is menopausal hormone therapy, MHT, or hormone therapy. And the reason is to make a clear distinction. If you've lost your hormones before age 40, in those situations, it's truly a replacement where we're trying to give you physiologic hormones back. Versus menopausal hormone therapy in the typical menopausal years is just a little bit of support to meet the needs of that individual. How do you know if you need it? So we're really oftentimes focusing based on how the symptoms are and also oftentimes how the bone density looks. I will tell you the national guidelines do say we're not supposed to be slapping everybody on a hormone patch and saying bye-bye, call it a day. It really is about individualized, weighing the pros and the cons. When you look at the U.S. population data, for those who are, a lot of obviously people in their 40s and 50s take hormones to help them with symptoms, but if you look at how many people in their mid-60s and beyond remain on hormones, it's actually a pretty small number. It's about 4% if you're looking at estrogen plus, or just estrogen alone, and estrogen plus progestin users, it's only about 1% of the population. So most people discontinue it at some point. In terms of the pros and cons, we think of a window of opportunity. It's also called the timing hypothesis, that if you're within a decade of menopause, that's when there's pros and cons, but the pros oftentimes versus the cons are a little bit more in our favor. And this is within a decade of menopause, meaning the final menstrual period, not necessarily when you started having symptoms. But when people are in their mid-40s or mid-60s and 70s and beyond, it's the same pros and cons that we consider, but those risks weigh a little heavier for most people. And the big risks that we worry about are blood clots, whether it's to the arteries or to the veins, and also breast cancer risks. So those, when you come in and you're talking to us, those are some of the risks that we're weighing for the benefits of like bone health and how you feel. That was a tough one. We can talk about that for 3 hours and just basically scratch the surface, I tell you. Which is why we do those shared medical appointments, so we get 90 minutes to discuss hormone therapy risk with patients. So Dr. Zipancic, this one's for you. What diet or lifestyle changes can be made to improve menopause symptoms?
I think that there are so many menopausal symptoms that maybe not touching on all of them, I'm going to focus on maybe two. So the two that I typically think of are the hot flashes and then weight gain. And we're going to talk about weight gain a little bit later today too. But when I think about like lifestyle choices or diet choices that can help with hot flashes, there are foods that we avoid because we know that they can trigger hot flashes. And there are foods that have been associated with improving hot flashes. So very common things that trigger hot flashes are, hot weather, smoking, caffeine, spicy foods, really sweet foods, alcohol, tight clothing, and stress can all trigger hot flashes. So avoiding those, it will be very helpful with diet and lifestyle changes. Things that can help with hot flashes. So there are some foods that have like plant estrogens in them. And when we think about those type of plants, they have isoflavones that kind of mimic the appearance of estrogen to our bodies. So foods that have those isoflavones include like soy. So common foods are like edamame, tempeh, or even tofu, chickpeas, lentils, flaxseed, and red clover. Cool foods are like a topic that are often brought up as well, like salads, cucumbers, watermelon, and then other things that can help just from lifestyle standpoint, quit smoking if you are a smoker, which everybody has many reasons to quit smoking already. Exercise, because that's been shown to help regulate body temperature. And then, of course, dressing in layers so that as you experience a hot flash, you can kind of peel off what you need and then put back on again when you get chilly. The other, big lifestyle thing that you can do with menopausal symptoms is manage your diet, which we'll talk about this further, but we do see an increase in weight gain and a difficulty with weight loss in menopause. And one of the best, and diets I think do sometimes get a bad rep, but one that's been consistently shown to help manage hot flashes and also improve your chances of getting to that centenarian status. I don't know if that's all our goals, maybe mine, but it's that Mediterranean diet. So that's a diet that's high in fish, extra virgin olive oil, high in fruits and vegetables and legumes like beans and lentils. You want to avoid high fat things like full fat cheese, red meat, skin on proteins, or refined flour products. So those are some dietary and lifestyle things that you can do to manage some of those more common symptoms.
It's a little depressing. Take out sugar, take out the cheese, take out the spicy food, but luckily Mediterranean food is yummy, so that's good. But people do feel better, you know, it's just hard to enforce, right? So Dr. Caponero, how can one determine if joint pain is a symptom of menopause, and if so, how can it be remedied?
If a patient is experiencing joint pain during or around the time of menopause, it's possible that that pain is related to hormonal changes. Joint pain is often accompanied by other menopausal symptoms like hot flashes, night sweats, vaginal dryness, and mood swings. While declining estrogen can contribute to joint pain, it's really important that we rule out other possible causes like arthritis, osteoporosis, or other medical conditions. And if you suspect that joint pain is related to menopause, or if you have any concerns, it's of course important to talk to your healthcare provider and make sure that we're ruling out all of those things and making sure that you have a proper diagnosis and plan. Some remedies for menopause-related joint pain include things like regular exercise. So low-impact activities like walking, swimming, or yoga can help to strengthen those muscles around the joints and reduce pain. It's also really important that we're working on weight management. So losing excess weight can reduce the stress on joints and alleviate some pain. We also want to make sure that patients are focusing on stress management. So using techniques like deep breathing, meditation, or yoga can really help to reduce stress and inflammation, which can also increase joint pain. And then, like we talked about before, an anti-inflammatory diet can be really helpful too. So focusing on foods rich in omega-3 fatty acids, fruits and veggies, and whole grains can really help as well. There are medications too that can be used, like over-the-counter pain relievers and some prescription medications. And hormone replacement therapy can help to replenish those estrogen levels, which may alleviate joint pain and other menopausal symptoms. There's also other therapies as well that we want to consider, like acupuncture and along with heat and cold therapy as well.
Dr. Collins, what can I do to make night sweats less extreme? I have eliminated alcohol and caffeine from my diet, but what else can I do?
Similar to what Dr. Zaponsic was saying about hot flashes, there's a lot of like diet and lifestyle changes that you can do to help manage or to deal with the night sweats, dressing in layers, you know, having an extra blanket around when you need it, those kinds of things. Definitely diet changes as far as like avoiding the caffeine, the spicy foods, and that as well. Additionally, things that you can do just to try to help your sleep in general continue, because one of the issues with night sweats is if you wake up and you're aware because you're going to the bathroom or you're waking up because you're anxious, the night sweats can be more bothersome to you as well. So the sleep hygiene that I think we talked a little bit about earlier, avoiding the screens right before bed, those kinds of things can certainly help. Additionally, there are some medications that can be really helpful to help minimize night sweats or to help, you know, sort of make them manageable. One of the things that we often pull for are, you know, one of the SSRIs, one of the classes of medications that can help not only with sleep, but also with the night sweats that they experience when trying to sleep. You know, trazodone, venlafaxine, to name a few, can be very helpful during this process, as well as hormone therapy. Progesterone, sometimes progesterone alone can be helpful with sleep, as well as the night sweats. Estrogen is also going to be very helpful. And so trying some of those diet and lifestyle changes, maybe trying some of the additional things that we talked about, an SSRI for a patient who either isn't a good candidate or doesn't want hormone therapy. But hormone therapy can be very helpful for these, and for the right patient can certainly make a big difference.
Dr. Zaponsic, this is another one about losing weight, because I know this is a tough and it's a question we get a lot. Is it harder to lose weight during menopause? Why is that? And I'll tell you, as this phase of life myself, it is hard. So can you give us some more tips on that, please?
Yes. So you definitely have a harder time losing weight in menopause, which is very frustrating. And a lot of information has come out that shows that a lot of us gain about a pound a year over that transition, which is quite frustrating. And about 20% of us gain over 10 pounds. So you're not alone in that either. Why does this happen, right? So in this menopausal transition, as our estrogens are decreasing, we'll find that this is also associated with increased muscle breakdown and then increased fat deposition, especially around our core. This is also complicated by the fact that after menopause, we have a harder time absorbing protein and then creating new proteins as well. And so we'll find that, unfortunately in this country, around 43% of women, pass that BMI of 30 or that obese character, that obese marker. And sometimes this is complicated as well by antidepressant use or hormone replacement therapy, because that can make us prone to this as well. Why does this happen in addition to the low estrogen? Well, as our estrogens drop, our testosterones tend to be a little bit unopposed and increase, and that can also predispose to that central adiposity. So the question becomes like, what can you do about it? So we'll find that because we have a harder time ingesting protein or kind of manufacturing the new proteins, there have been a lot of recommendations leaning towards higher protein diets. And because we tend to trend towards more central adiposity, keeping your overall caloric intake lower while also increasing your protein intake. And then if you look at any other study, done over the last couple of years, the number one thing that helps with weight loss or weight management is, limiting the amount of calories that we eat, which most of us knew that already. Then of course, exercise. It's also to know that, helpful to know that in menopause, weight loss is less rapid. It requires more sustained efforts than when we were young. And if you're doing all these lifestyle things and you're not seeing anything budge on the scale, which is very frustrating, you could be a candidate for like pharmacologic or surgical intervention. And there are multiple clinics through the Cleveland Clinic that pursue those types of therapy options as well.
Dr. Caponero, if a patient is on a hormone blocker, what other options do they have for dealing with menopause-related symptoms?
For patients on hormone blockers that are experiencing those menopause-related symptoms like hot flashes, night sweats, and fatigue, non-hormonal options include lifestyle modifications, which we've talked a lot about, antidepressants, and other medications. Antidepressants like SSRIs and SNRIs can help with hot flashes and mood changes. Other medications like gabapentin and clonidine can also be used to manage hot flashes. Additionally, lifestyle changes such as avoiding triggers, using cooling measures, and addressing fatigue can also really help. So like we talked about, some of those lifestyle modifications include some dietary changes, so reducing caffeine, alcohol, and spicy foods, wearing layers, using fans, and staying cool in cool rooms can also help provide relief from hot flashes. We also want to make sure that we're exercising well and we're sleeping well, and using a consistent sleep schedule can really help manage fatigue and overall well-being. We also want to always consider those relaxation techniques. So yoga, meditation, and deep breathing exercises can help manage stress associated with anxiety surrounding menopause. Like we talked about, there are a lot of other medications as well. So it is really important that you do make an appointment with your provider so they can go through these options with you and make sure that they find something that works well for you.
And this one looks like it's coming to me. How can you tell the difference between brain fog from menopause and age-related cognitive decline? It's a really good one because, believe it or not, anywhere from half to 2/3 of our patients are complaining about some sort of fuzziness, brain fog, cognitive concerns. And in fact, studies suggest that the more hot flashes you have, the more likely you are to experience some sort of issue with your memory. Now, the first thing I always say, talk to your primary care doctor, because a lot of people haven't had a basic thyroid checked or a B12 level checked. I pick up so much B12 deficiency for this symptom that is assumed to be for menopause. So you want to rule out some other contributors. Also keeping in mind that, if your mood is off, if you're not sleeping, all of those things affect our cognitive function the next day. Now, the science about about menopause and hormones and cognition is still evolving. It's very interesting. We're trying to put the puzzle pieces together, and really we need more science desperately in this arena. But what I will tell you, that on studies, they do demonstrate that women have a drop in certain parts of their brain function, and in particular, the brain parts for attention, the brain parts for verbal memory, meaning like, what the heck was that word? And working memory, where Somebody tells me a phone number, I'm going to remember it long enough to dial it, and oops, I need to look back at that number. So some of these domains, we do see a drop that's demonstrated in studies. Here's a little bit of the interesting part. Most people don't realize that women at midlife actually start with a competitive advantage in these domains. So in menopause, we have a drop, but it drops down to the rest of the population level. And so we just lose that competitive advantage. However, it's concerning, right? If you have a family history of dementia, because no joke, you know, Alzheimer's, our lifetime risk of Alzheimer's as women is somewhere around 1 out of 10. And how the heck do you know if this is something more serious? And so the way we've managed it at our clinic is that we have teamed up with our women's health, like brain specialists, and patients can be seen either for a shared appointment or one-on-one visit where they will do free cognitive testing. And that way you get a baseline assessment and you know where you stand, make sure there's no red flags or concerns, and that way you can follow things over time. And if there's a lot of symptoms, sometimes hormone therapy does help some individuals, but it's not a reliable way to protect your brain unless you are less than age 40. So if you're less than age 40 and you've lost your estrogen, or if you've had your ovaries removed at a young age, we do know in those situations giving back the estrogen helps prevent dementia, but we really need more studies to understand the role of hormones for dementia prevention. Dr. Zipancic, what is recommended to restore libido and increase pleasure during each stage of menopause?
The largest changes that I see in women after menopause kind of fall into two categories. So one is sexual desire, and then the other one is thinning of the vaginal tissue, which used to be called vaginal atrophy, but the newer, more correct term is now called the genitourinary syndrome of menopause. So kind of a long word, but really it refers to the thinning of all the tissues kind of in the vagina and around the vulva. So I like to start with the discussion around desire first. So sexual desire is very multifactorial. In fact, we're still trying to find like the perfect model to explain sexual desire, but I think the one that kind of meets all of the different facets of it is called the biological, psychological, and social model, the biopsychosocial model. So like what's going on with us biologically, like our hormones or medications that we're on. Psychologically, do we have like treated or untreated anxiety and depression? Because that can contribute as well. And socially, like how is the relationship with my partner? Are there children living in my house? Are they in my bed at night? Are the socks off of the floor? Are the dishes done? So we all have a very multifactorial list for desire for each of us. Where menopause kind of comes into play is more in the biological aspect. So, for example, we know that estrogen and testosterone both have a very positive impact on sexual desire. And we know that as early as 35, we have a drop in our testosterone levels, and then we have another big drop with menopause. And then estrogen, as we're talking about today, has a big drop in menopause. So a lot of the medications that focus on sexual desire in menopause focus on managing testosterone and then sometimes estrogen. We also know that in addition to hormones, there's some neurotransmitters, like the chemicals in our brain that like make us feel the way we feel, that are associated with increased desire. So specifically, we know that norepinephrine and dopamine make us feel sexy, but things like serotonin, like we often get with a lot of antidepressants like fluoxetine, really turn down our sexual desire. So there are medications that are focused on augmenting those, like making us feel sexy neurotransmitters as well. So if you look at the first line therapy for decreased sexual desire in menopausal patients, actually both ACOG, the American College of Obstetricians and Gynecologists, and ISWISH, the International Society for the Study of Women's Sexual Health, both endorse low-dose testosterone replacement therapy as first-line therapy for decreased sexual desire. We're not talking doses that, ideally are going to put like chinny chin chin hairs on or give you acne or hair loss. That's not our goal, but our goal is to maybe get you back to a little bit closer to towards that physiologic level or a little bit lower to meet your goals there. So we found that testosterone therapy at this low dose over short-term studies, there are no long-term studies with testosterone in women. We haven't seen worsening cholesterol, blood sugars, liver or kidney function tests, or links to breast cancer. But we do see an increase in desire, arousal, orgasm, pleasure, and a decrease in anxiety. So that's a medication that we can consider use for in our postmenopausal patients. Medications that are used off-label, which can increase norepinephrine and dopamine, fall into antidepressant categories like bupropion and Buspar. There are 2 medications out there currently that are FDA approved only for decreased sexual desire, and they are approved in the premenopausal population. However, there are some post-market studies that show that their efficacy is still good in the postmenopausal population, and those medications include things like bremelanotide or flibanserin. So there are options to include that are a little off-label as well. As far as that thinning vaginal tissue goes, that genital urinary syndrome of menopause, we know that estrogen keeps those tissues like thick, stretchy, and lubricated. And then after we go through menopause, over time, I see the most within the first 5 years after menopause, those tissues don't stretch as well. They're not lubricated. They're not stretchy. And often I'll have patients come in saying, like, it feels like I have lots of little paper cuts in my vagina after I have sex. So we'll see that tissue gets less fluffy, less stretchy. And that can also translate to the size of the clitoris as well. The clitoris should be on average about the size of a cotton swab or a little Q-tip, and that can shrink too. So when we talk about vaginal dryness, first line therapies are always the things that you can kind of find on your own, like vaginal lubricants and moisturizers. Second line therapies, if those aren't quite cutting it, there are vaginal hormones that come in the form of creams as both estrogens and a hormone called DHEA. And with persistent use, this is like a maintenance medication. This is something you would do as long as you would want to feel this way. You may have you may retain or regain some of that stretchiness, that lubrication, that plumpness in both the vagina, and if used externally, sometimes the labia and the clitoris as well. These vaginal hormones aren't classically associated with the risks of breast cancer or blood clotting disorders like the systemic or body-wide hormone replacement therapy. Certainly there's always a small risk there, but it's very minimal in the studies or almost absent in the studies that are done following women up to the 2-year mark. So those are some interventions that we could consider. And I'm off of my soapbox now about sexual health because I think it's very important.
That was spectacular. You covered so much. And I want to highlight also, because earlier when you were talking about weight gain, you mentioned testosterone being unchecked, contributing to some of the weight gain around the core. So it sounds like it's just balancing the right amount without overdoing it, but supporting at times when it's needed. Right. Dr. Caponero, how can I keep my pelvic floor muscles strong during perimenopause and menopause?
Adequate bone health is incredibly important to the pelvic floor. It's also really important that we're loading our tissues with good breathing techniques and mechanics. So in other words, this means that while weight-bearing exercise is really important, breathing properly during those exercises is equally important. Also, it's really important that we just don't think about our pelvic floor alone. Hip, core, and lumbar strength is really important too. It's also really important that you are getting adequate hormone support through your healthcare provider. So this may consider treatments like vaginal estrogen. I am a huge fan of our pelvic floor physical therapy team. I think that they do a fantastic job. I refer so many patients to them, and I think it's something that most women should actually consider. They don't really teach us this stuff in 5th grade gym class, and I feel like there's way more than Kegels that's involved with maintaining the pelvic floor.
Awesome, thank you. I couldn't agree with you more. I feel like our local pelvic floor physical therapists are worth their weight in gold. Dr. Zaponcic, are dry skin issues common with the hormonal changes in perimenopause?
Yes, they are. So we'll see that estrogen is associated with the collagen content underneath our skin. And so as estrogen decreases, that collagen content can drop as well. And collagen is really what's responsible for maintaining the moisture of the skin. So you do get more dryness, a drop in skin elasticity, and a drop in skin strength as well. It's also collagen. Collagen is also what kind of gives us that careful buffer between our skin and our blood vessels. And so as that collagen level drops, you may notice that your blood vessels become more prominent on your hands or your arms. And then when you bump into things, you don't have the cushion around those vessels that you had before. So you're more prone to bruising. And not to layer it on, but we were talking about, protein synthesis before. When you have these, bruises or any type of skin damage, it takes longer to repair those changes because it takes longer for that protein synthesis to occur. So when you're looking at ways to kind of protect that skin, the American Academy of Dermatology recommends some very basic things. Applying sunscreen every time you go out. It'll help fade potential age spots that you have, or prevent ones in the future from, occurring. Use milder cleansers than you did in the past, so you're not stripping all those natural oils away. Use the moisturizers that work well for you after bathing. Anything that has like hyaluronic acid or glycerin in it has been shown to help maybe maintain that moisture a little bit better. Estrogen therapy we've seen has some beneficial effects on skin thickness and elasticity when given at menopause, but it's not really falling within that FDA approval. In various studies, some show improvement and some do not show improvement in skin elasticity and strength. So most of this is going to be preventative and care as well.
Dr. Collins, we got a big one for you. What are the benefits versus risks of hormone therapy in perimenopause? Tough one.
I think that when you take that time to meet with your provider and you set up your consult to discuss these things, that is a great time to kind of sit through, go through your history and look at the potential benefits and risks for you. When we discuss the risks for hormone therapy, one of the most common things that we talk about is risks for VTE, which is like a venous thrombotic event, okay, or vascular thrombotic event. And so we talk a lot about risks of blood clots, okay, and these aren't blood clots per se, like when you have a period and you have clots that come out as part of your period. This is clots within the bloodstream. This is clots where we talk about clots in your lungs or clots in your legs. When clots happen in the vasculature or in the blood vessels, that can cause some catastrophic events. This is where things like strokes, pulmonary embolisms, heart attacks, those are the kinds of things that we talk about when we worry about when we think about clots in the vasculature, okay? And that is one of the things that we talk about and that we address when we talk about hormone therapy. And certainly it's a bigger risk in some patients than others. A patient who maybe has a family history, strong family history or personal history of these kinds of things. A patient who's a heavy smoker. These are patients where this conversation or discussion of this risk will definitely take more of the forefront than a patient who doesn't necessarily have those kinds of risks in their own personal history. One of the other things that we talk about is breast cancer risk. And so assessing a patient's history and breast cancer risk at baseline and talking about how hormone therapy might affect that, I think is part of the conversation that you have with your provider when deciding whether or not you're a good candidate for hormone therapy. As far as benefits of hormone therapy, there are so many and they're so varied. It goes so far beyond the hot flashes and the night sweats, although of course I don't want to forget about those things. But as we've talked about here, things like joint inflammation, skin changes, hair changes, libido changes, the process of perimenopause is so different for every patient. Some patients are going to be significantly more symptomatic than others, and those symptoms will take different faces and different names. And so going through what the patient is feeling and those symptoms and seeing, okay, these are different areas where hormones may benefit you, balancing the risks for that individual patient and deciding whether or not they're a good candidate, it is really, again, sort of an individualized approach.
Dr. Caponero, can you speak to treatments specifically for postmenopause patients dealing with brain fog, night sweats, low libido, etc.?
I think we've been talking about these the whole time, which is great. I feel like it's something that is so important and that patients are individually talking with their providers about their specific symptoms so that we can manage it specifically. One thing that I wanted to address a little bit more was the brain fog issue, just because it's something that comes up a lot with our patients. And while hormone therapy may be helpful in alleviating the menopause symptoms that may contribute to cognitive behaviors during midlife, it's one of those situations where there's not super reliable evidence as of today that shows that there's a cognitive benefit or harm associated with hormone replacement therapy. So all of these are really individualized conversations to make sure that you're addressing what you need and how to best approach it given your specific instances. Hormone replacement is wonderful for so many patients, and making sure that we are providing it for those patients that do have these symptoms is really important, but also looking at the whole picture, making sure that we're not missing something or that we're not putting a patient at unnecessary risk is also really important too.
And Dr. Zaponsik, a little left turn here. What exercises are best to prevent bone loss?
So really anything that falls within that weight bearing category. So these are things that where you're really contacting the ground, harder or lifting weights to kind of put some stress on the muscle and the bone, because bone growth really does occur through these little, it sounds scarier than it is, but like micro traumas, things that put stress on bone are going to build bone. So while I love things like swimming and cycling, for aerobic exercise, those actually really aren't giving you these little micro traumas or these like kind of, getting your feet on the ground type situations that are going to build bone growth. We think more along the lines of like jogging, dancing, lifting weights, and doing that about 2 to 3 times a week, which can really be helpful. And then other exercises that can be helpful just from a stability standpoint, anything that strengthens the muscles next to the spine that give the spine that extra support are really going to help with any potential structural fractures that you have in that spine as you may get older. Anything that you can do to support those joints that are more at risk for fracture are helpful. So any weight-bearing exercise that you can focus on, like the spine, the hip, or the wrists, are really going to benefit you as you go through this menopausal process.
Awesome, thank you. And then we have time for one last question. We covered a lot of ground. Dr. Collins, you did a very thorough discussion about the different supplements, but since this comes up so much, can you recommend any holistic treatments for perimenopause?
Yeah, and I think that this is actually a great question to kind of end things on, because I think one of the things that maybe we haven't talked a lot about is just sort of what women are going through with all of these symptoms and how that can affect their day-to-day life and their mental health and their relationships, and the importance of self-care, during this time frame. Focusing on, different treatments and things that will help you feel better, not only physically, but mentally with everything that you're dealing with perimenopause. I think I can't stress enough the importance of things like taking time for a massage, maybe a lymphatic drainage massage, which can be great for helping mobilize fluid and the extra fluid that you retain during perimenopause. The importance of acupuncture and various relaxation techniques, meditation, yoga, as well as really, committing to a balanced diet and exercise. All of these things, finding a hobby, focusing on your friendships. We talk about holistic treatments. I think that there's nothing more holistic than that, than self-care, and really focusing on where you are, how you're experiencing these symptoms and these changes, how they're affecting your mental health, and meeting that head on, addressing that, and finding ways of helping manage and deal with that to continue on and live your best life. So I spend a lot of time with my patients talking about those things. Again, we've talked about the supplements, we've talked about the diet changes, we've talked about the exercise, but all of the other things that I think that women in this time of life really can do to focus on to help with those symptoms, to help with their mental health, and to live their best life.
Thank you. To remind us about self-care, I realized last month, my kids, my dog, my cat, everybody's up to date on their vet and doctor visits except for me. So it's true for us caregivers too, and all women I feel like are caregivers. Okay, so that was our final question and the conclusion of our Ask the Experts event. Thank you so much for spending your evening with us. Before the end of the week, you will receive an email with menopause and women's health related resources, details on how you can make an appointment, and a link to recording of this event if you want to watch it again. Thank you so much for watching.